Hello and welcome. I'm your host, Neil Howard, here on Health Professional Radio. Glad that you could join us again. In this segment, we're going to have a conversation with Dr. Priya Prahalad. She's joining us here as a pediatric endocrinologist at Stanford Medicine Children's Health and clinical associate professor of pediatrics at Stanford University. She's joining us this evening to discuss how a technology-enabled approach to type 1 diabetes, inclusive of onset education, target setting, continuous glucose monitoring, and remote data review, helps decrease HbA1c levels in youth and also supports data dashboards that can allow medical teams to quickly identify which patients are in need of additional help, education, or guidance. Welcome to Health Professional Radio, Dr. Prahalad. Thank you for joining us this evening.
Thank you for having me on today, Neil.
What was it that led you into endocrinology and your work at Stanford Children's?
So I've always been someone who's really interested in technology and having long relationships with my patients. And so when I did my residency in pediatrics, I wanted to choose a field that combines the two of them. And so I chose to be a pediatric endocrinologist because when you're focusing on a medical condition such as type 1 diabetes, you're able to form long-term relationships with your patients. Some of my patients I've been seeing for over 6 years now. And in addition, a lot of type 1 diabetes management does involve technology, and I thought that together these would be a great field for me to work on. So following residency and fellowship, I started working at Stanford about 6 years ago. My role encompasses a couple of different things. Of course, there's clinical care and research, but I'm also a medical director in clinical informatics and quality improvement. So all of these have gone together in helping to develop our program for our patients with new onset type 1 diabetes.
A technology-enabled approach to type 1 diabetes. How does this technology-enabled approach differ from your standard endocrinology or type 1 diabetes care in pediatrics?
So type 1 diabetes is one of the most common chronic health conditions in children. It's an autoimmune condition where there's a loss of beta cells or the insulin-producing cells in the pancreas. So the management of type 1 diabetes is really challenging. It requires close monitoring of glucoses somewhere between 6 and 10 times a day, as well as insulin administration, historically by injections to cover your background needs, how many carbohydrates you're eating, as well as any high blood sugars you have. So as you can imagine, for children with type 1 diabetes or their parents, this is something that's really stressful and can lead to many changes in their lifestyle. And so with respect to why technology is really important for diabetes, say there was a study that resulted back in the 90s called the Diabetes Control and Complications Trial, which showed that very intensive glucose management can prevent the long-term complications of diabetes. And while some of these learnings have been implemented in practice, there were other aspects of the study that could not be done with the technology that was available. Mm-hmm. So in the study, people received insulin injections, much like what patients are getting now, but they also received very frequent glucose review by members of the diabetes care team. But with the technology that was available back then, patients would physically come in with glucose logs, and that's something that is a huge burden on patients and their families to do more frequently. So historically, insulin changes have been done at quarterly clinic visits, so about 4 times a year, or any time that patients or their families call in. But now with new technology, such as continuous glucose monitoring, you can receive that data remotely and make dose adjustments more frequently. And so what that means for technology-enabled diabetes care is patients are able to wear this technology and they're able to share this data with us, and we can proactively reach out to them in between these clinic visits to help them make dose adjustments and keep their glucoses more in the target range.
So you can continuously monitor the glucose, both the healthcare provider and the patient.
Exactly, in real time. So this continuous glucose monitor is a small wearable device. So it records glucoses every 15 minutes. So that's 288 readings a day. For the patient and any family members that are following the patient, they can see the glucose levels at all times. They can get alarms for high blood sugars, alarms for low blood sugars. And because this can connect to cell phones, we're able to see the data. So we've built dashboards that have helped us identify patients who would benefit from insulin dose changes, and we're able to proactively contact them to make those changes.
As a pediatric endocrinologist, how kid-friendly is this technology?
So the technology is definitely getting smaller and smaller, which is something that's very kid-friendly. And if you remember, I mentioned that typical care of type 1 diabetes requires 6 to 10 finger pokes a day.
Yeah.
With this, you're getting 288 readings, but there's one poke to place the CGM every 10 to 14 days, depending on the device that's chosen. So kids really love this because it's fewer pokes. Parents really like it because they can see the data at all times. And the other really nice piece about this data is it can now integrate with insulin pumps and do some automation of insulin delivery, which can also lead to improved glucose control, but also improved quality of life.
Tell us what are some of the factors to consider when implementing this type of technology, especially with children.
So the most important thing is the desires of the patient or the caregiver to make sure this is technology that fits into their lifestyle. We highly encourage continuous glucose monitors and insulin pumps for all of our patients with type 1 diabetes, but it may not be the right solution for everyone. The other piece with this type of technology-enabled approach where we're able to see the data remotely and communicate back and forth with families is to make sure we don't leave people behind. So being able to see this data is really dependent on having access to either a cell phone for sharing the data through cell phone technology or Wi-Fi and a Wi-Fi enabled device to share this data with us. And so this could lead to health disparities if you have people who don't have access to this technology. In our practice, because we've been doing this in the context of a study, we've been able to provide iPod touches and utilize Wi-Fi either at home or at school. But when expanding this type of program broadly, we really need to make sure we don't increase disparities. And I think the third thing to really also consider is cost or coverage. So these technologies are amazing, and we would love for everyone to be on it. But sometimes, depending on insurance plans, there may be very limited coverage or high copays. Depending on what state you're in, there could be no coverage for those with public insurance. So I think as a group, we need to advocate more for equitable coverage of these devices.
Could you describe the technology a bit more for us?
Sure. So one of the main goals of our clinic is to improve clinical outcomes in all of our patients with type 1 diabetes, as well as improving quality of life. And we decided to focus on patients with newly diagnosed type 1 diabetes because these are patients who are already receiving intensive education, and we wanted to intensify the education in order to improve outcomes. So we did this through a program called the 4T program, or Teamwork, Targets, Technology, and Tight Control. So as part of this, our entire diabetes team, which is multidisciplinary, worked together to have consistent glucose targets. And we started all patients with newly diagnosed type 1 diabetes on a CGM in the first month of diabetes diagnosis. As part of this study, they also received weekly remote patient monitoring. So the CGM data was shared with the clinic through the cloud, and our certified diabetes care and education specialists reviewed this data every week and sent messages to patients and their families with recommended dose adjustments. When we started the project, we were manually reviewing all of this data, but we then collaborate with some of our colleagues in the engineering department to develop a dashboard that can prioritize patients who would most benefit from CGM data review and dose adjustments based on their glucose numbers. And this really has allowed us to scale this study where we now have well over 200 people who we are performing remote patient monitoring on. And we saw an improvement in hemoglobin A1C of 0.5% compared to our historical controls. And because of the success that we had with this program, we started a similar program for our patients with established diabetes called the CGM TIPS program, or the CGM Time and Range program at Stanford. And in this group, we really targeted our patients with public insurance because there were some barriers to starting CGM in this group due to insurance coverage. So very similarly, we started them on CGM and did monthly CGM data review, which was enabled by our dashboard. And we're seeing huge improvements in their A1C as well.
What about active kids with fewer pokes, fewer interactions with their parents on a daily basis? With this thing pretty much being on autopilot, what are some of the concerns with the activities that children will be involved in, especially when their device isn't front of mind anymore?
So the devices that currently exist are hybrid devices. So they still require some input. So with the CGM, even if you're active or playing sports or on the go, you can still view this data, for example, on a cell phone. Mm-hmm. Some of our patients who are involved in sports will share the data with their coach on the sideline mm-hmm. or with their parents who are at work or at home. And one of the things you really want to watch for is, very low or very high blood sugars. And so having other people being able to see these numbers can help people intervene and stop a child from going very low. And with the closed loop pump systems I had mentioned, there is some automation of insulin delivery, but these are hybrid systems. So there is still some human interaction that's involved. So you have to be able to put in how many grams of carbohydrates, for example, that you're eating, or being able to troubleshoot. And with more and more of this data being shared through the cloud, even though people are not as hands-on, there are more eyes that could potentially look at it and identify problems or troubleshoot if needed.
Give us a website where our listeners can learn much more.
So you can learn a lot more about these resources at stanfordchildrens.org, where we talk about some of these technologies as well as some of our ongoing studies in developing a technology-enabled approach to diabetes care.
Doctor, I appreciate you sharing some of your time this evening. Thank you so much for joining us here on Health Professional Radio.
Thank you, Neil, and thanks again for having me.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Priya Prahalad. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.